Hola, bienvenidos todos a un café con el experto, este podcast de Citic. El día de hoy estoy acompañado de un cardiólogo intervencionista muy reconocido, es alguien de un grupo extremadamente fuerte en el tema de intervención. Para mí es un gusto presentar al doctor Jean-Michel Paradis. Él está en Quebec, en Laval University, es el Hospital de Corazón y Pulmón de Quebec, y él trabaja de la mano de Joseph Rodet, que es un cardiólogo intervencionista también que ha sido punta de lanza en la cardiología intervencionista y específicamente en TAVI. Y hoy, con un experto de TAVI, con más de 150 papers publicados, con haber participado en más de 6 trials internacionales en el tema, hoy la plática tiene que ser muy buena. Jean-Michel, welcome to Mexico. Welcome to this podcast. It's our pleasure to have you here.
Thank you. It's my pleasure to be here with you, and it's an honor for me to participate in this great podcast. So
thank you very much. Well, having you as an expert, we have to take advantage of that, and I'll ask you, what are your thoughts about, with that kind of experience that you have at Laval, about some common things. For example, we have trials for probably all of these topics that we are going to talk about. But what's your own perspective, and then what's what we have for coming from data? So the first one, what do you think about doing TAVI? First of all, in Canada, is it TAVI or TAVI?
Oh, it's both. You can say
both.
both.
You can say
both.
TAVI, okay. Here in Mexico, it's TAVI.
Okay.
But
TAVI is fine.
Well, in Canada, what do you think about doing TAVI in asymptomatic patients with severe aortic stenosis?
So yeah, very good question to start with. So yeah, as of right now, as you know, the current guidelines in the AHA ACC is to do clinical surveillance for those patients who are asymptomatic of their severe aortic stenosis. The paradigm may shift in the future because of the early TAVR trial. So as you know, the early TAVR trial was recently published in the New England Journal of Medicine and was presented at TCT 2024 by Philippe Généreux. And I'm going to do just a quick summary of this trial, and then we'll discuss a little bit about my practice. And in this trial, 455 patients were randomized to TF TAVR with a balloon expandable valve, and 446 patients with severe asymptomatic aortic stenosis were randomized to clinical surveillance. And the outcomes were quite compelling because in the group that was randomized to transfemoral TAVI, the primary outcomes at 1 year occurred in only 27% of patients, and the primary outcome, which was composed of death, stroke, or unplanned hospitalization for cardiovascular causes, occurred in close to 45% of patients in the clinical surveillance group. So this kind of data may shift the paradigm in the management of patients with asymptomatic severe aortic stenosis. But when you analyze this kind of data, you have to consider the fact that the primary endpoint was composed of 3 things: death, stroke, and unplanned hospitalization. And the rates of stroke and death was similar in the 2 groups. In fact, the primary outcome was driven mainly by unplanned hospitalization. So I think that we're probably going to need some more data to try to better identify which subgroups of patients will benefit better from an early intervention with a TAVI procedure. And by gathering more data, what we'll do is that we'll be able to use the TAVI procedure more effectively and without causing harm to patients, and it will allow us to use the resource allocation appropriately. So my answer is not as clear as it probably should be, but I think that if your patient is older and has severe asymptomatic aortic stenosis. I think that we have the data with the early TAVI trial to intervene with a transfemoral TAVI. But if your patient is younger, then clinical surveillance is still a valid strategy, and you can still follow your patient, but you have to follow your patient very closely, every 6 months, every 12 months at most, but not every 2 years. Like, you have to do very good clinical surveillance.
What are you doing right now at Laval? Are you treating these patients with?
We're treating, as I mentioned, elderly patients with asymptomatic severe aortic stenosis. But younger patients, I'm not sure we're quite there yet.
Yeah. Another topic that is very, this is a hot topic right now, is the small annulus.
Yeah.
What do you think about small? Before I do this question, before you answer this question, what's the percentage, more or less, of balloon expandable valves versus self-expandable valves at Laval?
At Laval, it's probably 70% balloon expandable valve and 30% self-expanding valves.
Okay.
Including Evolute and the Accurate platform as well.
Okay, that said, so now the question is, how do you treat patients with small annulus?
Yeah.
After the SMART trial and...
After the SMART trial, I think that you definitely have to consider a supraannular platform. The Evolute platform was studied in the SMART trial, so I think that the data is very compelling, and especially for the hemodynamic performance of the valve. That being said, I think that there's a very interesting paper that was just recently published by Becky Hahn from Colombia, one of my former mentor, and she looked at the late clinical outcomes of patients with small annuli who underwent TAVI with a balloon expandable valve. So, and it was published like 2 weeks ago in JACC Cardiovascular Intervention. And this trial, it was demonstrated that patients with small annuli compared to those with larger annuli had very similar rates of bioprosthetic valve failure and similar clinical outcomes up to 5 years. So I think that my first choice of valve would be a self-expanding valve for a small annulus patient. But if I have other reasons to use a balloon expandable valve, I don't think I'm doing something wrong for my patient.
Yeah, for sure. Well, also that said, what do you think that's the main factor that will impact the durability of the valve? Is it the gradients at the end of the procedure? I mean, basal gradients, or is it more the dynamics, or is it more the tissue and how it's prepared?
Yeah.
What do you think is going to impact the durability of the valve?
It's once again a very good question, difficult to answer. In my opinion, I think that the number one factor impacting valve durability is calcification. So I think that tissue technology that prevents calcification of the transcatheter valve is very, very important to reduce your rate of structural valve deterioration. Concerning the patient prosthesis mismatch or the gradients after the procedure, I think that the jury is still out, because we have Australian data showing that an elevated mean gradient right after the procedure is associated with reduced survival at 3 years. That being said, as I mentioned earlier, we have data by the Columbia group showing that having elevated gradient at 30 days after the procedure was not necessarily associated with poor clinical outcomes up to 5 years. So I think that the jury is still out about mean gradient and patient prosthesis mismatch. But definitely calcium is an important factor of valve durability. The other thing I want to mention is that I think that procedural outcomes, immediate procedural outcomes is key to improve your valve durability. I think it's important to have a well-positioned valve, a good commissural alignment, and a well-expanded valve, a very symmetric valve. I think like the Accurate ID trial showed us that it's important to have a well-expanded valve. So I think that for the durability of the valve, it's important to have good procedural outcomes.
Yeah, for sure. And after this conversation, we're treating patients, younger patients,
Yeah.
so we have to think about durability. So also we have to think about the stepwise approach for those patients and the lifetime management of those patients. So what do you think? Because we can't generalize. It's an individualized decision and it's patient to patient, but in the vast majority of the patients, we can say that there would be a suggested approach to start with which kind of valve? An intra-annular valve, a balloon expandable valve, a self-expandable valve.
Yeah.
Why one? Or is there some bias for some valves or not?
So I think that you have to consider the life expectancy of your patient. So
Yep.
if the life expectancy of your patient is greater than 15 years, to say something like, I think that the valve that you're going to implant first has to give you good hemodynamics, no patient prosthesis mismatch, no pacemaker, or at least a low rate of permanent pacemaker. It is important to implant a valve that will allow you to reaccess the coronaries in the future. And the other important thing is to implant a valve that will allow you to do a TAV in TAV in the future. And another thing that is important to consider is that maybe you should implant a valve that will be easy to surgically explant later on in the future. So I kind of have a bias, saying that I kind of have a bias towards a balloon expandable valve in the first place. A small frame, a short frame valve should probably be implanted in the first place because it will give you all the options and it will facilitate future coronary access, TAV and TAV, surgical explantation in the future, and so on.
Well, last question, or your point of view. Here in Mexico, we have like 5 or 6 different devices, TAVI devices, different valves, all with data, all with support. But well, some valves with more support than others in terms of data, but all of them approved or by CE mark or by the FDA, but all approved. Having that, what do you suggest to young interventional cardiologists to start with? I mean, is it because a lot of people would try to do to try all of them?
No,
but as I think that you're going to answer, what's your main suggestion to stick to one valve and once they already like are comfortable with the device, then switch to another? And I mean not only brand, but also to first to start, for example, with a self-expandable valve, or first to start with a balloon expandable valve, and then to switch to the other implant form, or what's your main suggestion?
So I think that the most important thing is to be comfortable at least with one device. So you have to concentrate all your efforts being comfortable using one device and knowing exactly how to use it and to obtain good procedural outcomes. So I think that the answer to your question depends on how many cases do you do every year. So if you're doing 20, 25 cases, you don't have enough volume to use 3 platforms or 4 platforms. You should concentrate all your efforts being comfortable using one platform, either a balloon expandable or a self-expanding valve. And then I think that if your volume increases and you have enough volume, you should have in your toolbox at least a balloon expandable valve, a short frame valve, and a self-expanding supra-annular valve for those small annuli cases or those valve-in-valve cases with a small surgical valves in which hemodynamics will be very important.
Wonderful. Any final thoughts?
No, I think that it's a great time to be in the structural field right now.
Yeah.
A lot of data is coming out. I think that AR is a very hot topic right now. We discussed this morning during the Proctors meeting in Mexico. AR created a lot of discussion, and I think that it is now the kind of forgotten new valve disease. So I think that it's a very interesting time to do structural intervention.
Well, your opinion at the end in this field. Do you think that dedicated devices should be the ones that to treat the AR, or we can use our device because we are using it?
Yeah,
because it's just what we have right now.
Yeah, but it's a good question. I think that dedicated device will be great. The thing is that we don't have access to them as of right now in Canada, at least in Canada. So I'm looking forward to using them in the near future. But as of right now, we have to deal with devices that are made for aortic stenosis and use them in aortic regurgitation. We can obtain very good results, but you have to change your strategy to obtain good procedural outcomes.
Well, thank you very much, Jean-Michel. It was a pleasure to be here and to talk about these topics about aortic stenosis and TAVI. Thank you for being here and for supporting all the Mexican and other proctors here in Latin America. Thank you.
Thank you for the invitation. It's my pleasure.
My pleasure. Muchas gracias por habernos seguido. Les agradecemos muchísimo que hayan estado con nosotros en esta edición de Un Café con el Experto. Les recordamos que si están de acuerdo, activen las notificaciones, pues nos sigan y estén al tanto de lo que estamos haciendo tanto en Citic, en el podcast de Un Café con el Experto, como en los otros diferentes podcasts y obviamente en el Congreso que ya cada vez se acerca más del 11 al 13 de junio en la Ciudad de México. Muchísimas gracias y esperamos vernos en una edición más de Un Café con el Experto. Merci beaucoup.
Thank you so much.
Thank you very much.
Thank you.